Luckily, about 50 to 70% of people with epilepsy, their seizures will stop with anti-seizure medication. However, about a third of patients, about 25 to 30% of patients will have seizures continue despite being on anti-seizure medications. And those types of patients, we call them drug-resistant epilepsy. And anti-seizure medications, if you add more, they will not respond, so they need some other types of treatment, and one of the best treatment for those patients is surgical treatment. So today we'll talk in details about surgical treatments for epilepsy, what are those surgical procedures, how we do the testing, what is the best candidate, what are the complications, what are the benefits for you to be 100% informed to make better decisions about your own care. Why do we need to do epilepsy surgery? There are some important information you need to know as a background for this. In cases of anti-seizure medications, when the patients fail the first medication, the chances of it to be successful reaches to 70%. But if the first medication does not work, the second medication, the chances of it being successful and stopping the seizure is about 15%. And then if two medications do not work, the chances of any other medication is about 5% to even less. This statistic was a little bit debated, but anyway, overall, the chances of seizure freedom with medications in drug-resistant epilepsy is very, very low. And having uncontrolled seizures and epilepsy is dangerous. And we always fear this complication of sudden, unexpected death in epilepsy patients. So patients can actually die because of their seizures. They can get into accidents. They can get into injuries. So having uncontrolled seizures is very dangerous and even life-threatening in many cases. So it is very, very important to do everything we can to treat those seizures and take this seriously. What are the testing that we need to perform an epilepsy surgery? Doing an epilepsy surgery, we need to do multiple tests, and all of those can be done at your epilepsy center. So first of all, you need to find an epilepsy specialized center. Those are the centers that are qualified and certified for epilepsy. If you search epilepsy center, you will find them all over the world. And we will start by doing an EEG, or epilepsy monitoring unit. We admit the patient to the hospital, we do long-term EEG with video, and then we record the brain waves during the seizures, and then we hopefully record multiple seizures to see the brain waves during the seizures and what happens. So first of all, we surprisingly find that about a third of cases that are labeled as refractory epilepsy do not even have epilepsy at all. Yes, they don't have epilepsy. They do have something called psychogenic non-epileptic seizures or other non-epileptic events such as arrhythmias in the heart, hypoglycemic events, or some other causes that are not necessarily epilepsy, and those will be treated accordingly based on the final diagnosis. However, if the patient was having epilepsy, we need to answer one more question: is what kind of epilepsy are we dealing with? Are we dealing with generalized epilepsy, means seizures are coming from all over the brain? This is a specific condition about genetic causes. They will have shaking seizures, myoclonic jerks, and then absent seizures, and those are treated with medications and devices, and usually resection of the brain is not an option. The other type of seizures is focal epilepsy. This focal epilepsy is caused by a focal area, like one spot in the brain, a scar or abnormal formations or stroke or tumor or whatever, that there is a lesion or an area in the brain that causes the seizures to happen. So it's important as a first step to differentiate what is that. The second step we do is to get imaging of the brain. We can do a brain MRI. A brain MRI is a detailed picture of the brain that tells us what is the structure of the brain, and we have epilepsy protocol brain MRI that we can go in details and do thin cuts and modeling of the brain, so that gives us a better chance of detecting anything abnormal in the brain. Other testing can be supplemented based on specific cases like PET scan. So PET scan is we inject a dye that has glucose and a dye that goes into the brain, and the areas that are having epilepsy will not light as much as the other areas of normal metabolism, and then this will guide us where in the brain the seizures are coming from. Another test can be a SPECT scan. So SPECT scan is a scan that we do during the seizure. We inject a dye, and then the brain that is having a seizure will work a lot more harder, and then it will capture more dye and it will light up more, and and then we scan the patient after the seizure 24 hours or so that we can compare during the seizure and outside the seizure, and that will give us a picture of where the seizure onset is. Other supplementary testing can be MEG, magnetoencephalogram. With this, the magnetic fields of the brain and localize where the seizures is, and we can even map language, sensory, as we explained in the MEG video. We can localize the function of the brain areas by doing functional MRI, like to evaluate where the areas of talking, sensation, or motor function. And at the end, we can perform a WADA test, which is injecting anesthetic into the brain. Half of the brain will be anesthetized so that we can test the language and memory in the other half, and then we do vice versa so that we can test the language and we can test the memory in both parts of the brain. And then we can send the patient to a comprehensive neuropsychological evaluation, which is a detailed memory analysis of multiple functions of the brain so that we can isolate if there is an area of the brain, like let's say hippocampus is affected, so there will be some verbal memory issues. If the patient has vision issues, or every brain function can be tested so that we can know where there is a disturbance. Also gives us a baseline before the surgery. If we have like any memory implications, after the surgery we can test before and after. At the end of collecting all those information and doing intracranial monitoring, we sit down together as a committee and as a surgery conference. We sit down together with epilepsy neurologists and neurosurgeons and neuropsychologists and all the team for epilepsy and even the neuroradiologists. We all sit down together. We discuss all the details about the surgery and the data, and we provide a recommendation as a whole team which is the best surgery to move forward with. And this practice is very good, and that's why we need an epilepsy surgery center to treat epilepsy. All right, we did all of those testing or some of combination of those based on your doctor's evaluation. Then we go sometimes to surgery right away, which means like if we see a scar and all the seizures are coming from, then we can take it out surgically. Or we can, like if we have like some idea of where in the brain, like which side the seizures are coming from, but we're not like 100% sure to a spot where it is, then we can do intracranial monitoring. Means we study the brain from inside. Like for example, if the seizures happen like all the United States map, let's say that the seizures after doing it, we know it's from the right hemisphere, like maybe right temporal area. So we can say like, oh, it's in the northeast of the United States. And then by doing more SPECT scan, all of that, we'll say like it's in the state of New York. And then we need to know exactly where, which city block. That is done by the intracranial monitoring. We put in leads in the brain to know where exactly the seizures are coming from. We study the brain networks so that we can plan the seizure accordingly. Also, we can map those areas from inside the brain by doing either grid, which is like a strips on top of the brain, or we can do depth electrode or stereotactic EEG. It's kind of like we know after that with coordinates, like where in the city of New York, and like a seizure will be starting in the Times Square. So like kind of very precise accuracy where the seizures are coming from so that we can minimize the risk of damage to other brain areas and only take out the area of the seizure onset. The perfect candidate of epilepsy surgery is somebody who has focal epilepsy and then there is a lesion or a scar in the brain, hopefully in the temporal area. The best perfect candidate is patients who have right-sided epilepsy, because the left side of the brain is where the language is. So we kind of concerned more about that. Right-sided temporal lobe, mesial temporal sclerosis, this is like the perfect candidate for epilepsy surgery. What are the chances of epilepsy surgery helping you? The chances are great. In epilepsy surgery, the chances of it helping you, especially in temporal lobe lesional cases, can be from 50% all the way to 80%. So that's a great chance compared to 1 to 5% in cases of medications alone. And other types of surgery, like if the case is patients who have like seizures in multiple areas, we might not be able to do the resection. We resort to devices, as we will continue describing in this epilepsy surgery series. Other types of epilepsy surgery, if the seizures are extratemporal in the frontal lobe, parietal lobe, or occipital lobe, sometimes the chances of seizure freedom a little bit smaller, especially in non-lesional cases, because we could not like precisely know where the seizure is. But every patient is different. Is epilepsy surgery dangerous, and what are the complications of epilepsy surgery? Epilepsy surgery is considered a pretty safe procedure, and the complication complication rates are very low. There are some complications to any surgery like bleeding or infection or nerve damage. Those are all expected, or stroke in some cases, but the rates of epilepsy surgery complications are generally low. And if we kind of like pool all the complications of all the surgeries together, it will be like between 4 and 5%, or even maximum to 8%. So it is very, very low complication rates compared to the lots of complications from uncontrolled epilepsy over the years. Look at this map that has multiple epilepsy surgery per complication rates per country, and look at this, like there is a huge discrepancy and differences between countries based on the procedures and what they report as a complications, and if the complications are considered long-term or short-term, all of that. So see, like it's a huge difference. It can be also to the experience of the centers and the surgeons in that area. Some people will look at complications different than others. So for example, if somebody has memory issues and then they are like a teacher or a student or a doctor, then the memory disturbances after brain surgery in the temporal lobe might be more significant to them than others. So what people feel about their complications might be different from what we as doctors perceive. So everyone has like kind of their own perception of the complication rates. And we should know that uncontrolled seizures can worsen the memory over time, as we described in the memory and epilepsy video. However, having seizures usually worsen the memory if it's not treated, and sometimes taking out those areas of the brain that are responsible for memory can cause memory loss, especially in temporal lobe epilepsy. At the end of the day, our job as doctors is to provide you with evidence and provide you with all the information you need to make the diagnosis yourself. What we do is we sit with the patient and their family. After going all the testing, we will tell them with numbers what are the chances of the surgery works, what are the chances of surgery not, what are the potential complications, and so on. And then I will have the patient go and see the neurosurgeon. We call them functional neurosurgeons. They do epilepsy surgeries, and they will sit with the neurosurgeon, explain the procedure, go over all the potential complications and risk and benefits. And once you have all of that information, then you can decide by yourself. But I want you to be 100% informed before making decisions, because sometimes the lack of information is what is preventing you from making those decisions. And then you start assuming, oh, it's a bad surgery, it's complicated, it's a brain surgery, all of that, and you are missing on lots of opportunities to render you seizure free. Do I need to take medications after epilepsy surgery? The answer is yes. After epilepsy surgery, people will need to take medications for their seizures, so that I think of it as in epilepsy, there is a network that causes the seizures to happen, and we take out the major node of the network, so now it is open. And then epilepsy medications will keep that network open so that does not clock back in and cause seizures to come back. Remember, we did the brain surgery, there is some scars around that area, and there is a chance that seizures can come back because of that. So we keep medications to make sure that the success continues and we don't have seizures coming back. However, in some cases, if the patient is on 3 medications and no seizures are happening, we consider decreasing the amount of medication so that you tolerate them better. But it's all individualized based on one patient and one scenario. Every patient is different, and the testing after the surgery will be different for every patient. What is the cost of epilepsy surgery? And lots of patients say like, oh, nice, that looks good, so I want to get a surgery for myself. How much does it cost? Unfortunately, in the United States, we cannot estimate the cost of any epilepsy surgery. The reason why is because there are lots of testing that needs to be done and lots of different procedures and different things. So we cannot estimate the cost remotely until we see the patient and plan the surgical treatment. Then we can estimate the cost more accurately. I advise you to go see the epilepsy center in your area or your country, and then discuss with them what are the potential treatments, what they can offer you, and all of that, and then you can be better informed about this situation. There are new technologies available to treat epilepsy, and one of those great technologies is laser ablation. So we can do the epilepsy surgery now using laser. And to learn more about the laser ablation and how it can help and treat epilepsy, you can see this video explained everything about the laser ablation in epilepsy. And stay healthy, and see you in the next one. Salam.